We're going. Good evening, everyone, and welcome to our Understanding Health talk from University Hospitals Dorset even. Thank you all very much for joining us. We're very grateful for you all coming along to this very interesting talk. We're also very grateful for Amanda Hillard for giving the talk. She, as it says here, is a clinical nurse specialist and works across Poole Hospitals, University Hospitals Dorset, which is fantastic. Before we begin, just to quickly reflect on the exciting times that we're going through at University Hospitals Dorset. A lot going on with developments across our sites, but also doing some very interesting things, such as our outpatient assessment clinic at Beals, which opens before Christmas. So lots of news. What I've done is I've posted a quick link to our latest sort of membership newsletter magazine in the chat bar. So please do have a look at that at your convenience. But also the chat bar, just to introduce it, is an opportunity to ask questions. So any questions you may have, please do post them in the live event Q&A. So you should see some question marks at the top of your screen. You can post questions there and we'll go through them at the end of the talk. Amanda's going to talk for about 45 minutes. And then we're sort of going to run through some questions with her and seeing some questions already coming in, which is really good. So just to say thank you again for coming. Thank you very much to Amanda for doing this talk, and we look forward to the Q&A at the end. Thank you all very much.
Hello, good evening, everyone. People know me as Mandy, and I'm menopause nurse specialist at Poole, as you've just heard, and I've got 30 years experience working in the menopause. I first started working for a charity for the menopause in London, and then I set up the helped set up the Poole Menopause Clinic 25 years ago. So as you can imagine, I've got just a little bit of knowledge in the area of menopause. My talk this afternoon or evening is for anyone who is going through or experiencing the menopause, whether that's personally yourselves or whether you're supporting your partner, a member, work colleague, friend. Just last week we had Rod Stewart, and I'd never thought I was going to say Rod Stewart in the menopause in one sentence, but Rod Stewart was on Loose Women, and he admitted that he found it really difficult to support Penny, his wife, as she was going through the menopause because of his own lack of knowledge and understanding. He wasn't able to support her, and he suggested that perhaps there ought to be classes for men so they could understand more and be more supportive. And he has a point in that, because I think a lot of us don't understand what's happening to our bodies and understand what's happening when we go through the menopause. So this evening, I'm going to cover the menopause, what it is, the symptoms, the long-term health implications, and some of the help and advice that's out there to hopefully help you. So by the end of the talk, hopefully you will have a little bit of knowledge and have picked up some hints. So let's start. I also would say that menopause is a vast subject, and trying to fit it all into 40 minutes is quite difficult. So if I don't cover anything that you're interested in, then please do post a question and I'll do my best to answer it. So let's start by looking at exactly what is the menopause. Well, the word menopause just literally means your last menstrual period. Not because you've had surgery and had a hysterectomy where your womb uterus has been removed, but because the ovaries, which are the two walnut-sized organs that live in the low abdomen, stop working and stop producing the hormone estrogen. And it's the loss of estrogen that's the cause of many of the menopausal symptoms. The average age of having your last period is around about 50. It's around about 51.8 in the Western world, so between 50 and 52. But the ovaries just don't stop working overnight. It's a very gradual process where they will wind down over a number of years. And so typically for a woman experiencing her last period at around about 51, it's highly likely that her ovaries have been winding down from her early mid 40s, about 46, 47. And this phase is called the perimenopause. Periods might change during this time. They can become heavier, lighter, further apart, closer together, and the whole cycle may change. And some women may start the early symptoms of the menopause with hot flushes, night sweats, and mood changes. Once periods have stopped for over a year, this is then called the post-menopause. So the menopause transition is the perimenopause, when we see periods changing, symptoms starting, then we have the menopause, and that's followed by the post-menopause. An early menopause is one under the age of 45 and a premature menopause under the age of 40. That's it. So what are the causes of the menopause? Well, the main one is natural, as I've just said, where the ovaries will wind down over a number of years, producing less estrogen, symptoms can start, and then obviously the periods stop altogether and you go into the postmenopause, and you're postmenopausal for the rest of your life. But some women have surgery where their ovaries are removed, and that causes an instant menopause. So the ovaries are removed, the estrogen levels, which we store in our fatty tissues and in our bloodstream, drops very quickly, and symptoms can start within a few days of having surgery. Chemo and radiotherapy can also affect the ovaries either temporarily or permanently, and again can cause an early menopause. And there are rare causes of chromosome disorders. And I'd just like to spend a couple of minutes just looking at premature ovarian insufficiency or premature menopause. So premature ovarian insufficiency, it used to be called premature ovarian failure, but we don't use that term anymore. The connotations of failure, and also sometimes the ovaries don't completely fail and there is a little bit of ovarian activity. So we call it today premature ovarian insufficiency or early menopause, premature menopause. Although this only affects a small number of women, it can be a devastating diagnosis. Not only have to deal with all the menopausal symptoms and the long-term health consequences, which young women of their own age are not experiencing. A lot of the literature that you see will be geared more towards the old women, but also the implications on their lives and lifestyle of having a diagnosis of a premature menopause. So as I said, there is a small number of women, but significant, it's 1%. 2% are teenagers, and we're seeing the incidence of this increasing due to childhood cancer survivors. So the treatment that they receive is great because now they're surviving, but unfortunately for some young women, they will go through a premature menopause because of the treatment they've received. Also, premature ovarian insufficiency accounts for approximately 1/4 of women who present to their primary healthcare team, GP, practice nurse, nurse practitioner, with amenorrhea, and that is loss of periods. So that's quite important that 1/4 of women whose periods have stopped under the age of 40 will be experiencing a premature menopause. What are the causes of premature ovarian insufficiency? Well, we have two causes, primary and secondary. Primary is where periods don't start at the beginning, and these can be due to chromosome disorders such as Turner syndrome and genetic abnormalities and enzyme deficiencies. And then we have secondary causes where periods do start, but then will stop at some point before the age of 40. And again, we've got chromosome disorders such as Turner's mosaic and Fragile X syndrome, autoimmune diseases, severe infections such as mumps, iatrogenic, which we've just talked about, which is surgery where the ovaries are removed, radio and chemotherapy, and idiopathic. And idiopathic means unknown. And I think that's probably for a lot of women one of the most difficult diagnoses, because there is a non-unknown cause. If you've got a reason why this has happened, why you're going through a premature ovarian insufficiency, it's not easy, but it makes it more acceptable. But if you have no known cause, then that can be really difficult to accept. We also know that women, through the research that's been done, that women who go through a premature menopause show clear evidence of premature aging within months of going through a premature menopause. And this was research done where women had their ovaries removed, that's BSO, bilateral salpingo-oophorectomy, under the age of 45, and they were shown to have premature aging in multiple systems, bones, heart and brain. And NICE, which is the National Institute for Clinical Excellence, recommend that women should be, or young women should be given information and encouraged about taking hormone replacement therapy because of the long-term health effects. And it should be, and premature menopause should be treated as any other endocrine failure. So if you had an underactive thyroid, you would take thyroxine. If you've got underactive ovaries at a young age, you should be recommended to take estrogens and take it until your early 50s, if not longer. So whatever age you are when you're going through the menopause, these are the effects and the symptoms that you are likely to experience. The acute symptoms, which start in the premature menopause or early menopause, are hot flushes and night sweats, headaches, palpitations, dry and itchy skin, lack of energy, and psychological symptoms. Once estrogen levels have dropped and we see that the periods have become very irregular or have stopped, then we have the symptom of vaginal dryness, and then the long-term consequences of osteoporosis and heart disease, which occurs many years after the menopause. Vasomotor symptoms, which are the hot flushes and night sweats, can cause a lot of problems, and a lot of women have severe symptoms, and they're experienced by about 60 to 80% of women. So not many who will get away scot-free without having at least one hot flush. Every woman will experience them in a different way. Some women will go red, some women will sweat, and some women will have a rise in body temperature, and some poor women will have all three. They last on average for 3 to 7 years. There will be a small number of women who will have them for 10 years plus, and there will be some women who have them for life. But we would hope that as you get older, they won't be as severe as when you first start the menopause in your 50s. And I've certainly met women in my clinic in their late 70s who have had hot flushes since their early 50s. Sorry, I've gone on too far there. Hot flushes can have a huge impact on life. Some women will be having hot flushes every hour, and they can interfere with work, daily activities, and if you're having night sweats, they can interfere with sleep, cause fatigue, loss of concentration, low mood, kind of effect on family life, because if you're having hot flushes, night sweats, you don't always want to take part in what's going on around you, and that can lead to affects the sexual function. Let's go. So they can have a huge impact on life, and as I say, these are one of the early symptoms, and the most common symptom is what brings a lot of women to see their GPs and practice nurses. There are also the psychological symptoms, psychological problems, and some women can get these without having the hot flushes. So these are standalone symptoms. So mood swings, feeling very emotional, low, tearful, angry, anxiety, irritability, sleep disturbances. This can lead to loss of memory and concentration, which is commonly known as brain fog now. And if you're having all of these symptoms, and it's going to have a knock-on effect on your confidence, and you won't feel like yourself. And this in turn can affect libido. Now, not all women will have all of these symptoms. Some women will have one or two. They might have a few hot flushes, or they might have a bit of sleep disturbances, but there will be some women who will experience all the menopausal symptoms. Once periods have stopped, we generally see the effect on the vagina and the vaginal walls. It sometimes occurs before the estrogen levels have dropped enough for periods to stop, but usually it's a symptom we see once menstruation has finished. And as I said, this is the effect of loss of estrogen on the vaginal walls. So if you look at the picture on the top, which says premenopausal vaginal epithelium, you can see it's a nice, thick, healthy layer with good secretion, so the vagina is well lubricated, and it has a good pH balance, so protects us against infection. If you look at the bottom picture, where you see the postmenopausal vaginal epithelium, then you can see it's a very thin layer. This is not as healthy, it's not as lubricated, so it's dry, it can bleed on contact, the pH balance changes and means we are more prone to infection. And this is all due to the loss of estrogen. Now, this can lead to vaginal dryness, painful intercourse, reduced sex drive, and for some women, because the vagina actually shrinks slightly, becomes slightly shorter, slightly narrower, the clitoris can also become slightly smaller, they can find it difficulty in reaching orgasm. The urethra, through which we pass urine, is made up of the same tissues as the vagina, and some women, when they go through the menopause, also experience bladder problems. The pelvic floor is also incredibly important to women. It's what holds everything up. And we need estrogen to produce collagen to help to keep the muscles elasticated. So when you go through the menopause, you can lose collagen and therefore lose elasticity. So the pelvic floor can become a little more lax. This can then lead to frequency in passing urine, having less control, having to get up at night, and more prone to infection. And again, this is all more common in the menopause years. So the things we've just looked at are the things that occur generally in those menopause years. So in the sort of 5 to 10 years after the menopause. Now we look at the long-term risks of going through the menopause, and these occur many years later. And the first we look at is osteoporosis. Now this slide looks at a woman as she's aging, looks at the woman's skeleton rather as she's aging, and you see that she has osteoporosis of the spine. You can see how she's bending over, the spine is beginning to curve and she's losing height. Osteoporosis is the thinning of the bone density to such an extent that the bones become thin, weak and brittle and can fracture easily with minimal trauma. And this occurs in trabecular bone, which is the hips, the spine and the wrist. And a very common fracture is for a woman to trip over a step or a piece of carpet, put her arm out to save herself and end up with a fracture of the wrist. Now, both sexes, male and female, will reach peak bone mass in our early 30s, and we all then have age-related bone loss. But the biggest difference between men and women is the menopause, because when women go through the menopause, in that 7 to 10 years, that is when women lose the most bone density and why we become more at risk from osteoporosis than men. And there's also the effect that menopause can have on heart disease. I don't know if you know this, but heart disease is the commonest cause of death in women over the age of 50, more than all the female cancers put together. And the menopause is implicated in this. Of course, there's a lot of other things that can be the cause, and I'm not an expert, and this would be a whole lecture in itself, but the menopause is definitely implicated. Under the age of 50, very few women have heart disease, but over the age of 50, you see this risk increase. It is thought that if treatment such as hormone replacement therapy is started in the early menopause, perimenopause and early menopause years, it may be of benefit in helping to reduce this risk. The same effects are not seen if you start HRT at an older age. So if you're 65 plus, then HRT may not have the same benefits. And we call this the window of opportunity. So starting HRT in your late 40s, early 50s may, for some women, have a beneficial effect. So how do we diagnose the menopause? Is there any fancy tests that we need to do? And the answer to that is no. The most important thing is for the health professional to listen to you, because you will tell us your diagnosis. What's happening to your periods? Have they become irregular or completely stopped? What are your symptoms like and when are they occurring and how old are you? So if you're over the age of 45 and your periods have become very irregular and you're starting menopausal symptoms, then we would say this is perimenopause, diagnosis of perimenopause. If your periods have stopped, then of course that would be menopause. If you've had a hysterectomy, then again we would go on your age and the symptoms that you're experiencing. The only time that we would definitely do blood tests is for those women who are going through a premature menopause. Again, we need to listen. You would tell us what your symptoms and what's happening to your periods. And then we would recommend a blood test for follicle stimulating hormone. This is FSH. This is produced by the pituitary and is the hormone that will encourage the ovaries to work if there's a problem. Usually this would be very low in our bloods. But when the ovaries are not working well, then this level would be increased and you'd see a high level of FSH. And so for women who are going through a premature menopause, we would recommend 2 tests to be taken 4 to 6 weeks apart. But even then, we would say this is not a definite diagnosis. This is just to build up the picture, because a blood tests are only a snapshot of that one particular day and can change. And so we would then listen to you, see what's going on, and then take the blood test as part of that diagnosis. And when women are going through the menopause, we have to look at you holistically. Hormones are not the only things that are changing, particularly as we are getting older. There will be aging, having to suddenly wear glasses, your joints becoming quite stiff, and other things may be going on. And changes within the environment, children leaving home, not leaving home, or coming back again with all their belongings. changes in working environment, having to care for elderly parents and relatives, and even the death of a parent, however old we are, can be quite traumatic. So we have to look at you as a whole and be aware of the limitations of the various treatments that are out there that can be helpful. As we're talking about changes in working environment, let's just take a moment now to look at menopause in the workplace. And if you go back a few years ago, it was totally unrecognised, and a lot of women felt alone, not able to cope, and trying to work while dealing with all their menopausal symptoms, with no one in the workplace really understanding how they were feeling. And so a lot of women unfortunately had to reduce their hours or stop work altogether. That has changed over the last few years and is now being widely recognised. In 2019, there were over 4.3 million employed women in the UK between the ages of 45 and 60, and many of these were going through the menopause transition. So this was a huge number of women of which we can't afford to lose in the workplace, and they have knowledge and experience. So a lot is being done now. A lot of the unions, such as Unison, is doing a lot to see how we can look after women when they're going through the menopause and what we can do to help them. The police force have done a huge amount of work, as has supermarkets and department stores who employ a large number of women. The National Health Service is also doing its bit, and you'll be pleased to know that University Hospital Dorset HR are also HR department are also doing a lot to try and find out what we can do to make work life better for women as they're going through the menopause, and hopefully keep you all here working. So what can we do? How can we help you? What is out there to help manage your symptoms? Now, a lot of women, some women may not need any help. Some women do cope very well with their symptoms, and they manage them perfectly well and should never feel pressurised into taking any forms of treatment unless you want to. And likewise, if you're having severe symptoms and feel you need treatment to help, you shouldn't feel guilty that you need HRT to help you. There are lots of different types of treatment, and again we would look at it holistically. What else is going on? What other things can we do to help? There are lifestyle opportunities to reduce health risks, alternative therapies, HRT, and other drugs that can be prescribed. So we know that when you have a hot flush, you have something called vasodilation. This is where the blood vessels dilate. And there are some foods and drinks that unfortunately don't help that. And one of them is alcohol. So alcohol causes vasodilation, and that can trigger the hot flushes, as can caffeine, tea, coffee, chocolate, fizzy drinks. So reducing these can be helpful. We also know spicy foods can trigger hot flushes as well. So we're not saying, or I'm not saying, you shouldn't have any of these. Obviously, if you can, try and limit them, because that can help with the hot flushes. But you want to have a night out, and if you go out and have a spicy meal with a few glasses of wine and a cup of coffee, it may be that the next day you're going to suffer with your hot flushes. But you would know that then and be able to manage it. And these things are about managing your symptoms rather than curing them and getting rid of them. We also know that stress, anxiety, like this poor woman here, trying to work, trying to probably, she's got to go to the supermarket on the way home, she's got to walk the dog when she gets home, all sorts of things to do, and anxiety and stress can also trigger hot flushes. So again, anything that's going to help reduce that stress. Yoga, Tai Chi, Pilates, mindfulness, cognitive behaviour therapy, anything which is going to help reduce the stress will help reduce the hot flushes. We also know that when you have hot flushes and night sweats, your body temperature does increase. So it's not in the mind. The body temperature can go up between 2 and 4 degrees. So the whole thing is to think, keep cool. Have a fan on your desk, next to your bed, in the kitchen, windows open. The rest of the family can freeze. They can sit there in their scarf and woolly hats. You can sit there in your t-shirt. So try and keep cool. Drink lots of cold water. Wear cotton fibres rather than synthetic fibres. Wear layers so you can take a jumper off and then put the jumper back on again. And some women actually get quite cold once they've had their hot flush. There's also something called the chillo, and this is a pillow that stays permanently cold. It doesn't have to go into the fridge, but it stays permanently cold and absorbs body temperature and can be very useful at night. I would also recommend a cold water bottle. So rather than this time of year when you'd be filling up your bottle with hot water, fill it up with cold water and ice, because again, that can be helpful. There are also lifestyle measures that we can try to help reduce our symptoms and to help with our overall well-being. We know that exercise is excellent. It produces good endorphins, which is great for well-being. It's good for our hearts, it's good for our waistline, and it's great for our bones. It helps preserve bone mass. It importantly maintains muscle strength and stability and coordination. We've talked about things that can be left out of your diet, and there's things that we can add in, which I'll talk about in a moment. Also, reducing your alcohol. Increasing calcium, vitamin D in your diet is great for your bones. Bones need calcium, but it can't be absorbed without vitamin D. Hopefully our diets are rich in this and we get vitamin D from the sunlight, but obviously certain times of the year, such as now between November and March, our vitamin D levels can be low and it may be worth looking at a supplement. Reducing smoking for well-being and for your bones. And if you've already been shown to be at risk from osteoporosis, look at prevention of falls. And there's a whole range of different alternatives that women take, and this is not an exhaustive list. There's loads of different things that women take. Unfortunately, they can be really expensive and they don't always help. Black cohosh and red clover are the two that NICE recommend, and the reason for that is because there are very limited trials on the other products that are available, and some of them have been shown to be no better than taking placebo, and we're not aware of their safety issues or their drug interactions. Whereas the red clover and black cohosh have been most studied and have been shown to help relieve some menopausal symptoms. NICE, as well as recommending black and red clover, they also recommend cognitive behaviour therapy, CBT. There's lots of courses available online and you may find those helpful. And it's a way of changing your behaviour and dealing with menopausal symptoms. And phytoestrogens, you may have heard of these. These are phytoestrogens are similar to estrogen molecules and come from a source of plants. Now, this is research that's been done in Far East Asia, where Far East Asian women appear to have fewer menopausal symptoms than Western women. But of course, their whole lifestyles are completely different. But their food is rich in soya, which appears to help with menopausal symptoms and is one of the phytoestrogens. So if you increase the isoflavones, the flavonoids and ligands in your diet, it may help overcome or relieve you of your hot flushes and night sweats. If you're already on a plant-based diet, then you will be eating a lot of these food products already. Now, it is quite difficult to eat a lot of this food. In the Western world, we probably eat between 1 and 2 grams of phytoestrogens, whereas Far Eastern Asian women, they will be eating in excess of 40 grams. So as you can see, you're going to have to eat an awful lot of phytoestrogens. So one way is to take a supplement such as red clover, which is widely available. I'm not promoting Premensal. The only reason that picture is there is because that's the company that has done the most amount of work and most amount of research on red clover. And it does appear that it is safe and there are low risks in taking it. So that's another supplement that you might be interested in. Oops, I've just gone a bit too far. There we go. And prescription does. What else can your general practitioner, nurse practitioner do for you? Well, again, there are a number of other things that can be prescribed, but the ones in yellow here are what NICE don't recommend should be used first line. Again, because of the lack of research specifically for use in the menopause. They all have their own uses. So clonidine is used for high blood pressure, venlafaxine for depression, gabapentin for pain. But we don't know really about their benefits as far as menopausal symptoms are concerned. And they are not licensed for use for menopausal symptoms either. And NICE recommend that we should use hormone replacement therapy and vaginal estrogens first line. However, there may be women who can't take HRT or don't want to take HRT, in which case some of these products can be helpful. So, hormone replacement therapy, what about it? There is so much in the media and on the news and in women's magazines now. Should you be taking it or shouldn't you? What are the benefits of taking it? Well, the benefits as I've just shown you, it will relieve menopausal symptoms. It will get rid of those hot flushes, the night sweats, the mood changes. It will reduce the risk of osteoporosis. That's very well established with research, and it may have other health benefits such as reducing the risk of heart disease. But what about risks? Well, any medication that you take will have risks, and HRT is no different. And there will be a risk of thrombosis and breast cancer, but they are small, and I'll just go through those. Talk about breast cancer first. So we must remember that all women have an individual baseline risk. So just by being a woman, we are at risk from breast cancer. And it is a multifactorial disease. It has all sorts of reasons. If there was just one, then we would know what that was and we wouldn't have breast cancer. So there are lots of causes, of which HRT may be one of them. However, when we look at it closely, estrogen alone has very little or no change in its risk. With combined HRT, which is estrogen and progesterone together, and I'll talk about that in just a moment, that's associated with a small increase in risk. And it's really related to duration of time. So the longer you're on it, the more at risk. But you need to be on it for 5 to 10 years before you see an increase in risk. And this is really with older women, not younger women. So if you're going through a premature menopause and starting HRT at the age of, say, 35, 36, that 5-10 years does not apply to you. You can take HRT up until the age of 50. There's no increased risk. The risk is for older women who are starting HRT in their 50s. This is just a graph that I like to show, which just compares it to other things in lives that we do. This is 1,000 women that you see in the grey there. If you look at the top line in red, that's 15 women who will get breast cancer anyway, without being on HRT or hormones. If you look at the third line down in lime green, this is women who are on estrogen only therapy, and it appears that they have a decrease in risk, but that's not the case. We would say that they have no increase in risk. But if you take combination therapy, which is the one above in the turquoise blue into dark blue, you can see there is an increase in risk, a small increase in risk with HRT. If you take it for over 5 years, there's a small increased risk. However, if you compare that with other things that we have in our lives, so if you are overweight, if you're obese, you have a large increased risk, a big increased risk of breast cancer. And if you do what some people do, some of us do, is that go home and have a glass of wine most evenings, then 2 units of alcohol per night will increase your levels. It goes from orange up until that sort of pale grey to the same level as women who are obese and overweight. So there are lots of other things that we do in our lives which will increase our risk. And so we do need to be aware of that and to compare that and be, aware that HRT is not the only thing that could increase our risk. And maybe it has a smaller increase than we thought. And what about thrombosis? Well, there is a small increase with HRT, with oral HRT, when you first start taking HRT during the first year. But that is only with the tablet, the oral form of HRT. There is no risk with transdermal, which are patches and gel. Again, all women have a low background and risk, and some women will have an additional risk, such as being obese, smoking, family history, in which case, in this group of women with other risk factors, we would certainly recommend transdermal therapy because it does not increase their risk anymore, rather than tablets or oral therapy. And if you go to see your general practitioner in primary care and you're in doubt and don't know what to do, then you can be referred to a specialist clinic. So what is hormone replacement therapy? We've talked about the risks and we know what the benefits are. Exactly what is HRT? Well, when you go through the menopause, it's the loss of estrogen, that's the main hormone, which is the cause of all the horrible menopausal symptoms we've just discussed. So that's the main hormone that we replace. That's the workhorse. That's going to do all the work and get rid of all the menopausal symptoms. And if you've had a hysterectomy, that's the only hormone that you need. And that comes as tablets and transdermal patches and gel. And there's various doses available. And one of the jobs of estrogen is that it builds up the lining of the womb, and that's what it does naturally, and that's what it will do if we give you just estrogen on its own. So it builds up the lining of the womb, and if that's left, it can become thicker. And so therefore we have to add in this second hormone called progestogen, and that protects the lining of the womb. So we get that that comes that's available as oral in combination with estrogen, so estrogen and progesterone together, and then transdermal with combined patches. The gel is just estrogen, so if you're on estrogen gel, you would have to add in the progesterone as a tablet. And we also have the Mirena Coil, which is the progesterone that sits in the womb and very gradually releases progesterone into the lining of and protects the womb. And a very little of it is absorbed into the bloodstream. And then you can add estrogen with your Mirena Coil in any way you want, whether that's tablets, patches or gels. So that's basically what HRT is, and this is the way that it can be taken. So this looks a little bit confusing, but I'll explain. It's quite, not too bad. The estrogen is shown in green, and estrogen is given all the time continuously. You never stop the estrogen. And at the top there, estrogen only is for ladies who've had a hysterectomy. If you're in the perimenopause and early menopause years and you're still having periods, then we add in the progesterone on a cyclical basis. So that's for 12 to 14 days each month, and you will go back to having a regular monthly bleed. The quarterly bleed, again, estrogen continuously, but the progesterone added in for 16 days every 3 months, hence the quarterly bleed. I have to say I don't use a lot of it, and the reason for that is some women do get very heavy periods once they stop the progesterone, but it is a good product and some women get on with it very well. Once you're postmenopausal and your periods have stopped, then you can have the no bleed HRT, where the estrogen and the progesterone are given together, and the progesterone stops the estrogen from growing the lining of the womb. And so that's the way that that we give hormone replacement therapy, and you would be suitable for one of those. What about vaginal treatments? Well, I think these are widely underused and are a great form of treatment. They're not hormone replacement therapy. They are local vaginal estrogens, which just work on the vagina and the surrounding tissues. They are very rarely cause side effects. Very little is absorbed into the bloodstream. They won't help with hot flashes or night sweats or protect you against osteoporosis, but they work beautifully on the vagina. And as you remember the picture from before, it takes your vagina from being postmenopausal into being premenopausal. And there are various ones available. There are creams, pessaries, rings, tablets, and generally they're used every day for a fortnight before dropping to twice a week. If you don't fancy that, or you can't have vaginal estrogens, then there are lots of non-hormonal preparations available. For lubricants, we have Silk and Yes comes as oil-based and water-based. And there's also moisturisers. Just as you would put a moisturiser on your face, you can also put a moisturiser on your vagina. And we have Replens and Regel, both of which work beautifully. What about testosterone? Because there's been a huge amount of this in the media recently, and I've had lots of questions from women about whether they are suitable for taking testosterone. It is a difficult subject. There is very little research on testosterone in women. Women do produce a small amount from their adrenals and from the ovaries. And it has been shown that women who've had their ovaries removed do have a drop in the testosterone level. Sorry. But for women who still have their ovaries, they will have a small drop, but whether that affects them or not is difficult to say. What we would always recommend is that if you have testosterone replacement, it is opposed with estrogen, and that you should go on to hormone replacement therapy first. See if this helps with your symptoms, and if continue with loss of libido and energy levels, then testosterone can be added in if necessary. But then that is our problem, because there are no or very few licensed products available for women in the UK. We do have Tibolone, which is very low dose, so it's a very weak estrogen, very weak progesterone, and has the androgen, which is testosterone. And so this doesn't often help with the hot flush, severe hot flushes and night sweats. And also, if you've had a hysterectomy, you'll be taking a progesterone, which you don't need. So we have to use what's available for men, but this is quite potent. So we then have to reduce the dose to one which is suitable for women. And Testogel and Testine, which are the testosterones for men, are not licensed for women. So they have to be used with caution. And the dose, as I said, would need to be significantly reduced. One testosterone that has been manufactured for women is Androfem, and this is specifically, as I said, for women. It's made in Australia and it is licensed for use in Australia. Unfortunately, it's not licensed for use in the UK yet, but hopefully in the near future it will be. But it is available on a private prescription if you can afford it, and it's about £120 a month, but that is the only one available. So more research does need to be done on the use of testosterone in women. We can use it, but with caution. So how long should we be on hormone replacement therapy? Well, for women going through the menopause in their 50s, we would say for symptom relief 3 to 7 years. Then to gradually reduce the dose, and if you're still getting symptoms, then on discussion maybe that dose would need to be increased again for a little bit longer, and to continue on HRT for a bit longer. But on general, 3 to 7 years, and hopefully by then the menopausal symptoms would have settled or become easier to live with. For prevention of osteoporosis, we would recommend 5 to 10 years, longer if necessary, if possible, for good protection. And nicely, there's no absolute time limit. It's got to be individual, assessing the risks and benefits for each individual woman. For those women who are going through premature menopause, we would recommend certainly up until their early 50s, if not longer. Once you come to stopping your HRT, we would again highly recommend that your dose is lowered gradually and that you just don't stop suddenly. As I said, when you go through the menopause, your ovaries gradually stop working over a period of time. And so your ovaries just don't stop working, and therefore you should just not stop HRT straight away. Otherwise, all your symptoms will come back, and we won't know whether that's because you're still menopausal and getting the menopausal symptoms, or whether it's because you've stopped your HRT. As you reduce the dose, if vaginal dryness becomes an issue, vaginal estrogens can be added in. And if you've been shown to be at risk from osteoporosis, then other treatments for osteoporosis can also be included. So in summary, the menopause presents an opportunity to build for a healthy and fulfilling future. If you go for the menopause at 50, you're going to probably be living 30 years. That's a third of your life in the post-menopause. The age of the menopause has hardly changed over the last 200 years. 200 years ago, it was around about 48, 49, and now we're talking 51, 52. Whereas our life expectancy has changed quite a lot. It used to be about 60, and now for women, we can expect to live into our 80s. As I said, that's a 30 years of our life, and we want to be healthy. Symptoms can have a huge impact on our quality of life, but there are a variety of treatment options available if you need them, going from complementary therapies through to hormone replacement therapy. And HRT is a safe and effective treatment for most women. And I think women need access to reliable, up-to-date and evidence-based information in order that we can make good choices. And we're all diverse, we're all different, all of us have different needs, and we should be assessed differently. We're individual women, individual assessment and individual treatment, whether we're going through a premature menopause, whether we're the older lady still getting symptoms, or whether it's our culture and religion means that we need different types of treatment. We all deserve to be treated as an individual. Thank you. I'm happy to take some questions, but here I've just given you some websites to look at. For any of you who are doctors and nurses out there, the go-to society is the Menopause Society, which has lots of good information, and you can have access to their pages without being a member. For women yourselves who are experiencing the menopause, or your partners or friends or work colleagues, Menopause Matters is another very good website. Women's Health Concern have some great fact sheets, and the Daisy Network is a charity for the menopause, specifically for women under the age of 40. Manage My Menopause is another website, and of course locally you have me and our menopause clinic at Poole Hospital for UHD. There is also a menopause clinic in Salisbury that's set up just a year or so ago, and I understand there's a menopause clinic in Southampton that I think is going to be set up in the near future. Thank you.
Brilliant, that was fantastic. Thank you so much for that. Really appreciated. Very quickly, I'm going to keep that slide up there just so people can take notes if they want to. But then we've got a lot of questions. Thank you everyone for posting questions. So I'm going to read through some of the questions for you, and then what I suggest we do, if you answer some now, but then what we'll do is we'll take a note of all the questions and we'll publish answers online, because we always like to publish a recording of the talk, also the slides, so you can see them, and we'll also answer any questions we don't get a chance to today. So please don't worry if you don't hear the answers to the questions today. So forgive me for some of my pronunciation as well, please. I've heard that you can take Hrt, sorry, I don't know what, capsules vaginally, and this can reduce some of the negative side effects of progesterone. I know this isn't an officially approved use, but this is widely talked about online. Is it possible to use it in this way?
Okay, yes, you're quite right. It isn't licensed for this use, but it can be used, again with caution, because we don't have the evidence that it is adequate for endometrial protection. So that's protecting the lining of the womb, as I talked about estrogen building up the lining of the womb. We would use it if women have progestogenic side effects. So if we try lots of different progesterones and they have side effects with them all, then we would look at using Utrogestan vaginally. And yes, you're quite right, you can have limited side effects with using it this way, but you should have that prescribed in a discussion with your health professional before doing it.
Fantastic, thank you for that. Next question. I suffer with mental health issues, mainly depression, and wonder what effect the menopause may have on it.
Yes, so we do find that women who have depression and other mental health issues, and there's some good evidence that if you've had postnatal depression and then suffered from premenstrual syndrome, then your menopause can be worse, I'm afraid. And yes, for some women who have mental health issues, when you lose the estrogen, I'm not sure that it directly affects it, but because all the menopause symptoms, the hot flushes, night sweats, not being able to sleep, that certainly can affect mental health, yes. So I would certainly, if you can in the perimenopause, have a discussion with one of your health professionals, nurse practitioners, practice nurse health, GPs, about what you want to do long term, whether it's going on to hormone replacement therapy, and put strategies in place before you get there.
Thank you for that. And we've got another question here. I'm 49, I've missed 2 periods. Is that normal? They were slowing down, getting less, and I've had no ovulation pain for a good 7 months, and I was always very regular. I've been suffering with long COVID since February, and lots of symptoms are the same. Not all, but chronic fatigue. I'm currently having tests as my cholesterol was high and started me on statins. My thyroid and diabetes came back normal. A long question there.
Okay, well, the fact that you're 49, so you're the right age for the perimenopause, and that you've now skipped 2 periods, yes, that would be completely normal for perimenopause and menopause. You're quite right that long COVID and menopause have very similar symptoms, not so much the hot flushes, but the extreme fatigue. And I've had some women asking me that question. It's difficult to know what's causing what. As I said, when we looked at those circles, you've got aging, environment, hormones, and I'm sure the long COVID is not helping your menopause, and menopause is not helping your long COVID. But the answer to your question, could this be menopause? Then yes, it sounds like it could be. I don't think long COVID would stop your periods.
Fantastic, thank you. Here's somebody who spoke to you on the phone the other day. Many thanks for your help. Yesterday I was informed that I may not be able to take Hrt. We won't know until final histology, approximately 3 weeks post-op. If I can take Hrt, are there any other treatments which might reduce menopausal symptoms? I bought some red clover, which I know you've discussed, capsules, but no, this will not replace estrogen.
Okay, so I'm assuming this lady has an estrogen dependent cancer, and so therefore Hrt will probably not be advised. There are lots of, so red clover you can try. So I think it's waiting to see what the symptoms are and how we can help with each individual one. So sometimes it's going to be taking a multiple of treatments to help the multiple of symptoms. And in which case we may look at some of the ones that I said that NICE don't recommend first line. But in this situation, maybe that's what we'll need to look at. So venlafaxine for low mood and hot flushes. Oxybutynin is also another one for hot flushes. So if you are somebody that's spoken to me before, then please get back in contact when you know your diagnosis and let me know what your symptoms are, and I will try and help you with each of those symptoms as you get them. It may be possible to use vaginal estrogens because very little is absorbed into the bloodstream. These can be used with women in women who've had cancers. So that's something we can think about and talk about in the future.
Fantastic, thank you. Here's one. How do I know if I am menopausal if I have a Mirena Coil as I don't have periods? Also got long COVID, another person with long COVID, unfortunately. So can't differentiate the symptoms to be menopause or long COVID.
Yeah, you're quite right. It is difficult once you have them. It's a bit like having a hysterectomy in that the Mirena Coil stops your periods, which is great, which is what it's there for, and particularly if you had it fitted for painful, heavy periods. Again, I would listen to you, look at what your age is, what sort of symptoms you're getting. Yes, we said extreme fatigue can be part of the menopause and long COVID, but hot flushes tend to be more menopause. Again, depending on what your symptoms are, and maybe if it feels you're the right age and you feel that it is menopause, maybe if that's what you want is a trial of HRT for 3 months to see if it helps your symptoms, and if it does, that might be your answer.
Brilliant. Next question. I've been on the contraceptive pill since 15. I'm now 49. My period stopped a few years ago. How would I know if and when I am going through the menopause? Would this not happen until I came off the pill?
Sometimes some women do get breakthrough symptoms. If you're taking the pill back to back, then you won't get a period. So if you've started doing that, that may be why you haven't got a period. At some point, you will need to stop the contraceptive pill and use other forms of contraception. And it's a difficult one with that because, it's that time of when you still need contraception, but it's time to come off and actually see what's happening to your body. And maybe you have to use barrier methods for a short while, just so that we can assess what's happening to your body and what's happening to your symptoms and what's happening to your periods. Because again, you're quite right. You will get a very blurred picture whilst you are on the oral pill.
Okay, here's a question. Any advice on how to get your libido back, or some kind of interest at least? Exclamation mark.
It is a difficult one, and I get asked that so many times. And if I had if I had some treatment, I'd make a fortune. I really would. It is a difficult one. There are lots of things that say that it will help. You can look on the internet, and lots of things are being advertised to help with libido. Certain exercise are supposed to help, and it is difficult. If you're not on hormone replacement therapy, that may be something to think about, or at least vaginal estrogen. See if you can make sex more comfortable. Hormone replacement therapy may also help. And if you're on HRT and it's still an issue, then obviously discussion of testosterone. We don't recommend testosterone on its own. We very rarely prescribe that by itself. So you would be looking at going on to some form of HRT, but unfortunately there is no miracle cure. And some women we do send for psychosexual counselling if we feel, or she feels, there is an issue between her and with her and her partner. So no, I'm sorry, there's nothing I can recommend apart from hormone replacement therapy and maybe testosterone.
Thank you for that. Here's a question. Had surgery for DCIS and was informed that I would be unable to have HRT as I was ER positive. Is there anything at all that I can take, or do I just have to bear with it?
Well, hopefully some of those things that I went through with you, looking at your lifestyle, what you can leave into your diet, what you can take out of what you can put into your diet, what you can leave out of your diet. Some of the treatments that maybe we can live, like I said already, venlafaxine, gabapentin, oxybutynin for hot flushes. So yes, it's going down, unfortunately, it is going down that route and trying some of the alternatives. So, not trying not to live it, try some of those things that can, and CBT, cognitive behaviour therapy, can be beneficial.
Thank you. And here's another one. Hello, I'm on HRT patches and have a Mirena coil for endometritis. So don't take progesterone. How often does the coil need to be changed?
For HRT, it is licensed for 4 years, but it is widely accepted with the Royal College of GPs and obstetrician and gynecologists that it can stay, and the sexual health is for 5 years. So every 5 years it needs to be changed.
And a follow-up call on the Mirena Coil here. If you have the Mirena Coil, how do you know what stage of menopause you're at, as you're not having periods anyway, which I think is
yes. And again, we would go on age and symptoms. And if you're not getting any symptoms, great. But there are a small number of women who don't get symptoms. I don't think I said that in my talk, but you know, there are a small number of women who do get away scot-free, and you may be one of those women. Don't tell your friends.
Another question on red clover here. If my cancer is found to be estrogen fed and I'm unable to take HRT, can I take phytoestrogens such as red clover?
That's a very interesting question, and the answer is we don't know. Phytoestrogens are very, very weak estrogens, and as I've said, if you're eating them in your diet, and if you're on a plant-based diet, then you're probably eating a lot of those anyway, and so you would be increasing your levels of phytoestrogen in your diet. It is thought to be that the risks are low with phytoestrogens, but I don't think the research is done, and we don't know. But it is very, very low. It's a millionth of a or a thousandth of a estrogen molecule. So it is incredibly low dose.
Thank you. And what happens when you stop HRT? Do you then have symptoms?
We would hope not. No, we would hope that whilst you're on HRT, you've gone through the menopause and your symptoms are stopping, or would have ceased. And that is the most important thing, that is to reduce your dose of HRT gradually. Don't just suddenly stop, because if you suddenly stop, you will get symptoms back. And we won't know then if that's still menopause or whether that's stopping HRT. So always reduce very, very gradually. And if at some point, as you're reducing, you're getting symptoms, then that could be that's what you're still getting. So we would then say, stay where you are, don't reduce any further, wait for those symptoms to settle before you carry on and reduce. But a lot of women, there's no wide tell that if you're on HRT, when you stop, you've got to go through the menopause again. And that's not the truth. Your menopause will be stopping, and hopefully by the time you stop HRT, your symptoms would have gone.
Thank you. This question is quite specific, so it may be one that we'd sort of pick up afterwards, but I'll read it out anyway. I'm 47 and perimenopausal. I started on HRT last week, progesterone tablets for day 15 to 26 of my cycle, and estrogen patches. Do I keep patches on all the time, even though I'm only taking progesterone tablets for 12 days? Why has my GP put me on a separate medication rather than combination patch?
Right, okay. You are on combination, so that's the first thing. Absolutely, you're on estrogen all the time, and yes, you take estrogen all the time, you never stop. Because you're perimenopausal and your periods haven't stopped, you're not quite ready for the bleed-free HRT, and that's why we're adding in the progesterone. Your GP's adding in the progesterone for 12 days each cycle. And usually I would say the last 14 days of the cycle. And the way I tell women is 14 days of estrogen and then 14 days of estrogen and progesterone together. 14 days of estrogen, 14 days of estrogen and progesterone together, and that goes into a 28-day cycle. And the reason your GP's recommended that is because you're still having periods, and we're trying to get you back into a 28-day cycle. So that's why you're having that. Why they haven't prescribed the combination patch all in one, I think there's a lot of media, there's a lot of people saying that Utrogestan, the gel in Utrogestan is one of the best HRTs. It is very good, but you're individual. I don't believe in blanket ruling. I think you have to have what's the best HRT for you.
Fantastic. We're going to combine the last question. I'm afraid we don't have any more time. But there's a question saying, do you have to be referred into the menopause clinic centre, and how long is the waiting list for the menopause clinic after being referred? So if we can combine those two questions.
Yes, of course. You have to be referred, yes, you do, just like any NHS clinic, by your general practitioner or your practice nurse practitioner. After this evening, I suspect my waiting list will be huge, but at the moment it's about to see me, it's 3 months. To see one of the consultants, about 5 months.
Fantastic. Now, we've had a couple of comments, so I'm just going to read one of them out here, saying how grateful people are for this talk, and then I'll add my own gratitude. But not a question, but just wanted to say how grateful and good that it is we have this sort of event being held for all staff at UHD to raise awareness. You mentioned in your own talk, Mandy, that women need reliable information on this, and I think this has been an absolutely fantastic example of giving that reliable information. So I just wanted to say thank you on behalf of the Trust for your talk tonight. As I say, we'll be publishing the recording of the talk. We'll be publishing the Q&A, and we'll also be publishing the slides. So thank you all very much for coming. Another comment just come in thanking you for such an informative talk. So a very good evening to you all, and thank you very much indeed.
Thank you.